We know that dense structures like bone stop and absorb more X-rays compared to soft tissue, and these will therefore appear white on the resulting image. Whereas soft tissues such as muscle and fat absorb very low amount of X-rays and appear as a shade of gray. Air is the least dense material and it absorbs almost no X-rays and thus appears black. This differentiation is important further as we'll discuss the basics of CT. The same principle follows. So that is why I'm revising it again here from the last class. So moving on to the important X-rays that we studied last class. This is a X-ray for a small bowel obstruction. So here on the first X-ray, on the left side, it's an erect X-ray which shows multiple air fluid levels in a staircase pattern. On the right-sided X-ray, which is a supine view, we have the dilated bowel loops which have the valvulae conniventes uh, seen. And so these loops are dilated jejunal loops. This is again a case of an obstruction. This is a large bowel obstruction. On the erect X-ray, you can again see multiple air fluid levels, whereas on the supine X-ray, we have dilated large bowel loops. Large bowel loops are characterized by the presence of ostrations in the large bowel wall. So, just to revise this, on an erect abdominal X-ray, we'll see more than 3 air fluid levels in a step ladder pattern. The other thing that we can see on an erect abdominal X-ray, the air under diaphragm, the limitation is that it has a higher radiation dose, and some patients may not be able to stand. So for these patients, we have the other view for the X-ray is the supine abdominal X-ray. Here we are able to see the dilated bowel loops. We'll be able to identify what is the type of bowel loop that is dilated. And the limitation of this projection is that the air fluid levels are less distinct here and free air or perforation might be missed on this X-ray. Now, once we have on a supine X-ray, we have established that we have dilated bowel. We also talked about the 369 rule, where in small bowel, the dilatation that is required is of 3 centimeters to call it dilated. So when the small bowel loop appears dilated to more than 3 centimeters, that is a dilated small bowel loop. In large bowel, that becomes 6 centimeters. And in case of the cecum, it is 9 centimeters. So when the dilated loops show valvulae conniventes, which are opacifications from one end to the other. These correspond to the internal mucosal folds of the jejunal bowel. So when we see valvulae conniventes, then the dilated bowel loop is jejunum. When we have ostrations present, ostrations are partial and they do not completely traverse the bowel. When ostrations are present, then the dilated bowel loop is a colon. And when none of these features are present and it's a featureless dilated bowel loop, then that is an ileal bowel loop. Now, here in this X-ray, we can identify all 3 bowel loops on the same X-ray. So the one in the right upper quadrant is the ileum. In the left side of the abdomen, it's the colon, and within the pelvis, it's the jejunum, highlighted in different colors. So the other important X-ray that we discussed last week was the air under diaphragm or the pneumoperitoneum X-ray. This is free air under the diaphragm. So on the right-hand side, the air under the diaphragm is free, whereas on the left side, the air that is seen is the fundal gas shadow, which is a normal finding in an X-ray. However, this free air under the diaphragm is the abnormal finding. The other important sign that we discussed was the regular sign or the double wall sign. Here, usually we are not able to visualize the wall of the bowel on an X-ray. So that is to visualize the bowel wall, it is only possible when there is air present both on the inside and outside the bowel wall. Then only the bowel wall can be seen as a single line. So this is known as the regular or the double wall sign. In supine films, it can help us diagnose a perforation even if the patient is not able to stand up for an erect film. Now we move on to the workings of a CT. CT principally works on the principles of X-ray, that X-rays, when they pass through when they pass through the tissues of our body, they are attenuated differently depending on what tissue they are passing through. Uh, Combining these X-rays with computer processing helps us obtain an image, which is a cross-sectional slice of the internal organs of the body. So uh, there are two added components compared to an X-ray. So these are a rotating X-ray beam and a detector, and a computer processing system, which will create the detailed internal slices, 2D and 3D slices of the internal body structures. So uh, this is a diagrammatic representation of what is happening in an X-ray. We have a gantry, which is this which is this donut-shaped structure. This structure has an X-ray tube and a X-ray detector. Both of them are rotating, and uh, the rotating X-ray tube takes multiple X-rays as it traverses around the body and takes multiple images. Later on, the computer analyzes all these images of the uh, of a single rotation that the X-ray machine has taken, and computes it to form a 2D image based on how the X-rays were attenuated by the different structure that it was passing through. So the parts of a CT machine, as we discussed, are a gantry, a motorized patient table, and a computer. So the gantry is the patient table moves in, and the gantry moves all around the patient to take an image. So unlike our X-rays, where we were using X-ray films, the CT scanners use digital detectors. These detectors would measure the intensity of the X-rays as they are passing out of the patient's body, and they would convert them into an electrical signal. This electrical signal is then sent to the computer as the raw data. The computer will then go on to process it to create a two-dimensional image slice. And each time the X-ray source completes one full rotation around the patient, the computer would construct a 2D image slice of the patient at that level. So this is the principle of a single detector computer tomography scan.